Hey everyone, my name is Cynthia Klein and I serve as the Project Director for the Take Heart Initiative. Just wanted to welcome everybody to today's session. Thank you so much for joining us. Today we're going to be talking through innovations that can improve your cardiac rehabilitation program. We are really excited about the presenters we have today and the discussion we're looking forward to as well. Before we jump into the session, let's go ahead and I wanted to provide just a few quick updates on the Take Heart initiative. As we've talked about before, we have two groups of hospitals that we work with under Take Heart. The first one is what we call partner hospitals, and those are the ones that have dedicated to improve cardiac rehabilitation at their facilities using automatic referral with care coordination. And we work closely with those hospitals to provide training and technical assistance over about a one-year period. I am very happy to announce that we have just recently restarted our partner hospital activities. So beginning this month, we have kicked back off those activities, kind of given where we are within the pandemic. The very first activity we'll be doing with this group is a refresher training called Ready, Set, Go, Getting Restarted with Take Heart, and that will be held next week, next Thursday. If you are interested in registering for the event, my understanding, I think, is that you can click this link and be able to go to it. We can also provide some additional information there as well. So this is the first two of our 10-session series, and we offer training modules at about a pace of one a month. You know, we have a group of hospitals that are starting with us now, and they will run through the program. We're also looking for a second group of hospitals. We anticipate having some space for some additional hospitals. If this is something you might be interested in, we would love to talk with you. So there's an email address here if you want to reach out to contact us. Right now, we're looking for that group to maybe start, you know, late summer into the fall of this year. So we'd love to talk with you if you have any interest. The other group of hospitals we work with are called our learning community group. And so if you are attending today's affinity group, you are taking advantage of one of the offerings we have throughout the learning community, and we do anticipate continuing to do affinity group meetings like we've got here today. We'll continue to offer those on a regular basis on priority topics. As we've mentioned in the past, these events are open to anyone, but we do encourage you to go ahead and join the Take Heart learning community here at the link that's provided. All right, that's our updates on Take Heart. I'd like to pass you over to the next leg of your journey, and I'm passing it to Steve Hines.
All right, thanks very much, and good morning or good afternoon, depending on which time zone you're in. As Cynthia said, we're really delighted that you're with us today. We want all of these events to be opportunities for everyone to learn, everyone to share, and everyone to support each other. We encourage you to use the chat for that purpose. We want to focus today on innovations that programs may have made in response to the COVID pandemic, but have realized actually benefit their program and their patients, and so they're making those things permanent. We don't want you to view your current situation as, you know, a push to return to a pre-pandemic normal. We want to view your situation as an opportunity to continue to evolve to better serve the needs of your patients in your program. So this is a moderated panel discussion. We'll be introducing the panelists in just a second, that uses chat and polling features to dialogue with the participants and allow you to communicate with the panelists as well as to other audience members. So today's experts, this will be moderated, as all our affinity groups have been, by Dr. Hisham Scali, the principal investigator for the project and the director of the cardiac rehab program at Brigham and Women's Hospital. And then we're delighted to have four panelists with us: Heidi Haglin, Jesse Hyduk, Sarah Schaub, and Matt Thomas. They all have really useful insights and have made changes that have benefited their programs, and they'll be talking about those over the next hour. So we did mention the chat function, and we want you to be aware of how to use that. We want to encourage you to set the field to say everyone, since that option will allow the panelists to see what you're saying, as well as all the audience members. So set that to everyone. If you want to send a short greeting to the group, use it just to try out the chat function. Go ahead and do that, and then use it again to ask comments, to make or to ask questions or make comments as we proceed through the event. We'll also be doing some polling during the event, and the polling function is pretty easy to use. The poll will open to the right hand of your screen, and that's where you'll submit your answer to the questions. And once you've done that, remember to hit the submit function, button, and then we'll show all of you the results so that you can see what your peers are thinking and compare your reactions to those of your peers. So let's start off that process by looking at this first audience question. And we'd like you to first tell us what describes how your cardiac rehab program is operating compared to before the pandemic. So you'll see that there are some options there off to the right. Everything is returned to how it was before the pandemic, or aside from some capacity limits, things have pretty much returned, or we've made some pretty significant and permanent changes, or we've made some pretty dramatic and permanent changes. So if you can pick one of those options, and we'll give you just a few more seconds to pick which option describes your program. And then I think we can start closing the poll. You still have time to answer, but go ahead and close the poll, and we'll look at the responses and see, and this will give our panelists an idea of where you all are at, that they can reflect on as they make their comments throughout the panel. So once those results are in, then if those can be displayed, and we will see, which groups each of you fall into. This takes a second to come up, but we should see the results here shortly. All right, and the results are, aside from some capacity issues, about half of the audience, things have pretty much returned to the same as they were before the pandemic, with some significant changes being the second most common response, and then everything has returned to exactly as normal, and dramatic changes being the rarest responses. All right, useful to know. Let's do one more question before we dive into the content for today. So if we can take a look at this second audience question, we're also interested in the patients participating in your program. So would you describe your patients as being essentially the same numbers, same backgrounds as the patients that you had before the pandemic, or fewer patients but roughly the same backgrounds of the patients, or fewer patients plus a kind of different changes in your patient mix between now and before the pandemic, or we've got as many or more patients, and this I think is the experience of at least one of our panelists, and your patient backgrounds have changed. That would be an exciting kind of development. Or you may say, candidly, we really need better data because we're not quite sure how our patient backgrounds or numbers compare to before the pandemic. So pick one of those responses. We'll go ahead and close the poll, and display the responses here. And it seems like the most common response is fewer patients, but pretty much the same backgrounds as beforehand, followed by same number of patients, but same backgrounds. And a handful have as many or more patients, and some different backgrounds of those patients. And that's a good development, because there are some underrepresented groups in cardiac rehab that we really want to encourage all of you to do more effectively, to reach out to. So those that are in that situation, we really encourage you to use the chat function to describe some of the things that you're doing, and react to the things that the panelists are mentioning. Having said this, I'm going to turn things over to Dr. Hisham Scali, and he can kind of overview the event and talk us through the insights from our panelists.
Thank you, Steve. And I want to welcome everyone to this other affinity group that we have, talking about some innovations that we've tried, and some of them work, some of them didn't work. And so we have excellent panelists today with that Steve already introduced, and we'll be talking to them, and I'll introduce them as we keep talking to them. I want to thank them also for making the time and to be here and to share with us their experiences, and I hope you will all benefit from this. We're curious to hear about what you have tried, whether it worked or not. Also, please do that in the chat box, and I'll make sure to relay that to the 120 people or so following this. So we will follow essentially the journey of a patient enrolled in cardiac rehab, essentially going from the intake and orientation processes, and then how things go when their patients are undergoing their rehab, either whether that's in person or and for exercise or related to counseling and education, and then the other delivery of cardiac rehab, which is related to virtual and remote cardiac rehab delivery. So without further ado, let's get started with that. We'll start with the first part. I'm sorry, I must have clicked 2 slides at once. And so let's talk about the patient intake and orientation processes are very important. This is where the patient gets introduced to the rehab program, gets to know what is expected of him and what is it or her, and what do they expect from the program. It kind of realigns the expectations and objectives, but it is the way for the cardiac rehab team to get to know the patients very well and be able to re-stratify them and help the patient to come up with that individualized treatment plan. So this is a very important step, and we will talk with our panelists. I'd like to ask Jessie Hyduk from South Bend, Indiana. Actually, she's been doing this for a while, and they come in her program. They've come up with group intakes, which I think a lot of programs have been doing on and off. But this is an opportunity for us to hear their experience and how the pandemic has motivated this. Jessie?
Thanks, Dr. Scali. So what we've done in South Bend is we've implemented group intakes, and we had talked about it prior to COVID, but it really kind of highlighted the need to do it. So as we resumed operations, we now do group intakes. And we see 3 patients at a time when we say group. It's 3 patients to 2 staff members. They're in our facility for about 1 hour and 45 minutes. And during that time, we do a group intro where we go over their consent, conditions of participation, we hook them up to tele, and we just go over the expectations of the program. And then once we complete that, then we're able to break them off into 3 stations, so to say, around the department. They meet with the nurse to go over their H&P and meds for about 15 or 20 minutes. They meet with an exercise physiologist or nurse to do anthropometrics and their 6-minute walk for about 15 or 20 minutes. And then they also have an individual station where they're independently working on their survey tools. And for here at St. Joe, we do the PHQ, we do the Rate Your Plate, and then we also take that opportunity to show them a short video regarding their diagnoses that enrolled them into the program. If it's an open heart procedure, or if they've had a stent, or if they're heart failure, it's just short videos to help them better manage or know about what brought them to us. And then we bring everybody back together at the end to schedule their ongoing classes, to continue to develop that camaraderie that we just really pride ourselves on around here within the cardiac rehab department. And then we are hopefully scooting them out the door within 90 minutes of the time they got here. So we've gotten some really good feedback from the patients, and just that support that we've seen from the onset from others, as well as from some patient videos we show, has just been outstanding for us.
Nice. So indeed, a procedure or a operation that was done before the pandemic, but has taken some, that has gotten some more uptake, And this is how you can get 3 people at once. And really, I guess with the shutdown, a lot of programs were not able to enroll their patients right away. And so the wait list has significantly lengthened in a lot of places. And so from this group intake, we're going to hear about another perspective from Matt Thomas. Matt Thomas is in Chattanooga, Tennessee, and oversees the program over there. And they went in a completely different perspective. Matt, do you want to share with us what you've been doing?
Yeah, so, very early on, like others, our program was completely shut down for a few weeks for our phase 2 and phase 3. And as phase 2 came back online, we recognized there was some reluctance for some of our patients to come, 1, to the hospital, and 2, have that one-on-one visit that we had been using prior. So we decided to shift everything to kind of a virtual format. So what we do now, and we're sticking with it because it's been working, is that we offer our initial intake either via Zoom or over the phone, depending on the patient's comfort level with the technology. And so we do all of the intakes that way, with everything from our code of conduct, our rules, our regulations, just the basics, and our outcomes. And so there are some challenges with doing the outcomes, especially over the phone, but we were able to adapt and change our outcomes to modifiable PDFs. So we can now email those to the patients before we have the session. They can fill them out, and then we found it was a little better just to be able to review with them. So really they do everything in the intake except the 6-minute walk test and the signature on their informed consents. We do that when they come on site for their first session orientation.
Very nice. So you've kept the informed consent as a pen and paper procedure, and the 6-minute walk test obviously also in person, and that allows you to bill for that exercise portion, but then the entire intake process is done either offline with the PDF forms and then virtually online with the patients. Also another creative way
Exactly.
of, have you found a problem or any difficulties with patients in their online access and ability to do that?
Some patients have been reluctant, and I'd say this was earlier on, to use some of those virtual platforms. There were all sorts of wild rumors floating around when everybody was dialing into things like Zoom, and that was coming online. But the further along we've gone, we've had a lot better reception to that. So I'd say if there was any reluctance, it's been with some of our cohorts wanting to use that platform, and they prefer just to do over the phone. The last thing I'd say, we've actually seen our participation rates improve for these initial intakes because it doesn't require someone to come on site, and we can catch them on the phone. Also has let us, if someone doesn't answer a call, we can grab the next file, call someone, see if they have opportunity. So we've really been able to speed up our lead times on getting patients in.
Very nice. And then for a third perspective, we have Sarah Schaub from Canton, Ohio. And Sarah, do you want to tell us how you've been doing it, the orientation and intake process?
So we have been doing things similar to what Jesse had described with a group orientation that we adopted after we had the shutdown. We had some pent-up demand. We needed to figure out a way to get more patients in efficiently. So our model is 5 patients, 3 staff members, an hour and 45-minute time frame. We utilize their first 2 sessions for this initial intake, 1 monitored and 1 non-monitored session. And then we have a nurse assessment, risk factor planning, 6-minute walk tests, and exercise goals that we set with the patient, as well as some individualized pieces. We found that this works really well. We're able to get our treatment plan signed the same day, and the patients are able to have that group, or the group aspect rather than the one-on-one, kind of get to know some people as they get started, as well as it's much more efficient process for us that we have virtually no wait to get patients in, whereas we sometimes would operate on a 2-week wait to get patients into the program. Now we usually always have appointments immediately available.
Very nice, and again, very encouraging. about how shift in process can actually improve outcomes. So we know there's data out there that shows that the shorter the time between your index diagnosis and the intake and enrollment and that first visit in cardiac rehab does increase the likelihood of enrolling and completing your cardiac rehab. Again, so that's so you can see here how the group intake or the virtual intakes have taken place and how are improving. So far, we're hearing that it is improving the process. And so once the patients are enrolled, we're in the program operations, and so there are a lot of opportunities for change there related to scheduling, to the structuring of your sessions, and then how the rehab process itself is ongoing. The exercise is ongoing during the sessions. So that's the next phase of our discussion. And so let's go back to Jesse, because I know you've made some changes that you are right now thinking of keeping permanent. Initially, it was an adaptation to the pandemic, but then hearing you might keep this even after the pandemic ends, which we all hope that it's going to be very soon.
So yeah, we went from what you typically consider in cardiac rehab of having a 60-minute class, patients coming 2 to 3 times per week, and we began to do 90-minute classes with our patients. The intent was to have them come for the first 30 days for twice a week for 90 minutes for each session. But as we found with our enrollment and our volumes being down slightly, we decided that these patients could come twice a week for 90 minutes for each session. And with that, we could then bill for a monitored and a non-monitored, or 2 monitored or 2 non-monitored sessions, depending on the acuity of the patient. So we were able to bill for 4 visits a week, which allowed us to get patients in and out of the program a little bit quicker, but also has allowed us to really hone in on their education, and allow them to once again get that support from their peers who've been through something so similar, that the staff can be there to help with, but we couldn't fully understand because we've never been in their shoes. So we've really seen some great patient relationships develop. And because of changing to 90-minute classes, we also then tweaked the hours of operation. Because we were operating with a longer class period, we gave ourselves a longer turnaround in between classes to finish up our paperwork, our ITPs, and turn everything over with all the new cleaning guidelines. So we stay open a little bit later 2 days a week, and we also began to offer classes on Fridays, which we typically didn't do in the past. So we changed our staffing model. We also lost a staff member. So we're down in FTE. We've decreased our volume, but by implementing the 91-minute classes, we've been able to attain a charge entry at about 73% of where we were prior to COVID, which I just think is great because our phase 2 volume is only at 38% of where we were prior to COVID. So we've really, honed in on that charge entry and business model in a cardiac rehab sense.
Very interesting. As you all know, cardiac rehab operations are struggling that fine line between your charges and your volume, and especially in the pandemic year, that makes it much more challenging. So again, another way of being creative, but also flexible in increasing the number of hours that you offer during the week, and also offering an additional day there, and whichever works and allows you to get patients in. Sarah, I know you've also changed the way patients come into exercise during the program.
So we made some changes regarding the amount of personal space that the patients would have. We're just maximizing the areas. We operate at 3 different locations, so the spaces are different, but we found a way to provide the patients with kind of their own home base, we call it, where they have a chair, they have their monitors, their electrodes, everything they need, even their own pen, their own blood pressure cuff, and the locations are spaced, 6 feet apart. And this is something we plan to continue. We feel like even as the pandemic is getting better, that people are going to be more conscious of having their own space and not having to be kind of on top of each other, putting their monitor on or interacting very closely. Not that they can't still interact. And then another thing that we've done is we've adopted more education during the session, so that the patients, we used to have them sit in like a group circle while we did education, and now we're doing it more while they're exercising, and that has added an element of personalization, so you can, when you're teaching something, you can kind of adapt it more to that specific patient. So we plan to continue that as well.
Very nice. And so a couple of questions came through the chat just to keep the interaction with our audience of about 120 people so far. Lori mentioned that they are more, they screen patients when they are doing that intake to make sure that the patients are more serious about attending at least and committing at least 12 sessions. And that allows the patient to derive as much benefits from attending cardiac rehab and increase their graduation rate, which I think is a very important thing. Patients who will be coming for just, 1, 2, 3, or 5 in the single digits don't derive the benefit that's expected from attending a cardiac rehab program. We know that it's a dose related response, and so people who attend 24 or greater sessions are more likely to derive a maximal benefit in terms of their functional capacity, but also in their mortality and morbidity benefits proven in cardiac rehab. So I think that's an important thing to realize. And if you are able to make the accommodations, such as what Matt was describing with virtual programs, which makes it easier on patients to continue, then that's a good thing. Heidi, we haven't heard from you. I'm sorry. So I'd love to hear what has been your experience so far.
We've done some similar things that Sarah had just talked about creating each patient having their own space, having their own chair, having their own blood pressure machine to go around with them during their exercise session. And that has really worked well, and the patients have responded well to that. They kind of appreciate their own space. To piggyback on what some of the other presenters have talked about, we have not switched our orientation process and we haven't gone to group yet, but I find what they have to say really interesting, and we'll have to take a look at some things.
Very nice. Matt, how about you? I heard, so we know that physical space varies from one program to the next, and sometimes even within the same institutions, they have different places and different hospitals, so that things are not always the same. Matt, how have you adjusted your cardiac rehab exercise program?
Yeah, and like Sarah and Heidi pointed out, and probably many on this call, early on we were really looking at minimizing our contact surfaces and optimizing our space. And so we recognized that we had a few bottlenecks, particularly when group classes were coming in, waiting in the lobby, going to their staging, getting hooked up on the monitor, etc. And so a non-monitored program had been on our radar for quite a while. We decided to just launch right into it so that we could take a few patients out of the equation for some of those bottlenecks. Really what it's allowed us to do is to spread out into our gym a little further, go just past that, the reach of our telemetry and our monitors, use areas of the gym that we were not able to use before. So optimizing that space. We've taken the contact down because we risk stratify these patients. So for our low and moderate risks, if they go through, just an example for our low risks, if they go through 3 to 6 sessions, they have no ectopy, no adverse reactions, abnormal blood pressures, etc., we will then move them to the non-monitored program. So everyone starts the same, and then they kind of, for lack of a better term, graduate to that non-monitored approach. It's really let us optimize our space and the number of patients that we can see, because we can now see 16 patients that are monitored, and we've added 4 more non-monitored patients, so we can just get more people through the door.
Very nice. Yeah, indeed. This being flexible again and adapting to what you can do to allow a greater throughput. That's what Jesse was describing, is can allow you to increase your charges and keep your program afloat. We were very saddened throughout this past year to hear about some programs that had to furlough employees or had to close down. And so anything we can do to continue to provide this service to our patients is extremely important. So this was, we talked about exercise, the portion of the rehab, and how about the education, the counseling, and as we just heard from Matt about the monitoring. I know that I heard with Jesse, we discussed before this, how you all again change the structure and the scheduling of your education sessions. Do you want to share that with the group?
Sure, I'd love to. So with our 90-minute classes, we really honed in on how we could make our education with the patients more robust. And in doing so, we really tried to find a way to provide education in like a hands-on way, in a handout, but also a way that they could visualize it and see it like on a PowerPoint or a video, so that we were hitting on multiple ways of learners and educators. So with that, we had one of our staff members bring in her Wii. So we do some stuff on the Wii with patients. When we're talking about stretching or resistance training, the patients are actually in the gym getting that education, and it's hands-on. We're constantly asking them to even call out the stretches we're doing for stretching or dynamic stretching or cool down. And we have like interactive videos and games like Jeopardy boards and tools that we have found online and on YouTube. There's so many resources out there. And, you know, we all have those repeat offenders who've been through the program multiple times. And the feedback we have gotten from those patients who've seen the program in one light and now have seen it in a new light have really given us some accolades as to how much better they feel the program is and how much more engaged they are with this new education platform.
Yes, so again, this perspective of having the hands-on experience, we see that with children, we see that with high schoolers, with medical school and physical therapists, and so we see that in the professional educational system, but certainly in the patient education, that's another experience that we're learning, and the data is there to support this, that the hands-on experience certainly increases that benefit. I mean, I'd love to see some data to see whether how that is sustainable and maintained after graduation. So, you know, that's another research project that some of you out there could do. And then in 6 months, how many patients can maintain and what they've learned with this approach. But very encouraging. Matt, how about you with the hybrid education? How have you been handling this?
Yeah, so the hybrid is something that's going to stay for us, and it came out of a response for, initially we were doing group classes each week in addition to our one-on-one wellness coaching format. And obviously when the pandemic hit, we were limited on how many people we could get together in a group, and that was the same for our social support program. And so we shifted everything to an online format. It did seem favorable at the time. The last thing we wanted to do was engage with our patients outside of that face-to-face, but Zoom is what we had available. So we developed slides and content for our core component areas, put everything together in that way, and started delivering our classes. Interestingly enough, we started getting more participation in those education classes. And, looking back on it, it's probably not that surprising when you're asking people to come early, stay late, come back to the center for that one-on-one. If they can pop on their cell phones, then it's a lot easier for them. We have seen some hilarious things over Zoom. Cats jumping all over stuff in people's houses and catching all sorts of fun conversations with our patients. But as they learn the platform, it's been fantastic. Now that we're coming back online, we've developed a hybrid because so many people wanted that to stay when we talked to them, just because it was easier for their schedules and they liked that delivery. Now we're doing the classes live, but we're also live streaming them through Zoom simultaneously. So that's our hybrid model, and I don't see it going anywhere. It's just convenient for those who want to stay and those who want to do it from home.
Very nice. So hopefully with the advocacy group, we can continue to do this and get more reimbursement for this virtual delivery method. And so we'll keep our fingers crossed then. Sarah, what are you doing? I know, but I heard we discussed before how you changed your blood pressure monitoring routine.
Yeah, so we, when we came back from the pandemic, we were trying to reduce, you know, how much contact we were having, close contact we were having with the patients, and determined it was a good time to look into taking less blood pressures. And it turns out that it has been beneficial for both the patients and the staff. Nobody seems to miss the extra blood pressures. We have sort of do more risk stratifying as far as who really needs one and who's stable without checking it quite so frequently. This has allowed the staff to have more times, especially during the exercise sessions, to interact with the patients, talk about risk factors, do education versus trying to go through and take everybody's blood pressure throughout the exercise. So this has worked well for us, and we plan to continue the reduced blood pressure measuring. It seems to work very well.
Yeah, I think there is some data out there questioning the necessity of checking blood pressure as frequently as we used to. And so probably there is a subgroup of patients where it might still be necessary, as you said, but it is likely that in a lot of patients, we don't need to check it as often, as frequently, and as regularly as we used to allow for a more streamlined exercise session without the interruption. And this gets me to a couple of comments in the chat box about, what we learned during the pandemic. Initially we were afraid of any contact, any close contact with breathing, but also with our hands. And, so where people were disinfecting and using rubbing alcohol and everything. And so what we learned is that likely it is not absolutely necessary. The rate of transmission of the virus with contact is not as high as we feared. It is still an airborne transmission in the majority of cases. And so following the CDC recommendations about continuing to wear masks in medical facilities remains important. So I know in our program, in our hospital setting and in outpatient setting, the recommendation is to continue wearing masks for both vaccinated and not completely vaccinated patients. In outdoors, we will follow your CDC and local recommendations from the states and counties, but within the medical facility, I think at this point, the risk might still be higher than outdoors. Very good. And so for the blood pressure thing, it is something that was done initially out of fear of the virus, but you realized and demonstrated that it is not, for the conduction of cardiac rehab, it is not absolutely necessary to check the blood pressure 5 times within the hour for this. Good. So our next topic for discussion is about how to be more creative and how to expand use of virtual cardiac rehab and virtual patient support. And so let's start with the expansion of virtual CR. And I think Matt has given us a few examples. So let's go back to Matt about, how you pivoted and how much of an increase in your participation rates you've seen so far.
Yeah, well, as I've already described, the kind of our arrival at virtual cardiac rehab was pretty organic. First we were doing intakes online, then we were looking for an answer to education. And, that's what this whole little webinar is about, right? Responding to the pandemic and seeing what works. So we had a lot of the pieces put together. So we just started molding that, and when the CARES Act came through, we saw those extensions to the end of the year. We are starting to see traction and advocacy and seeing the writing on the wall. It was just a natural fit for us to put a full virtual cardiac rehab, virtual delivery in place. So, you know, our model's very basic. Arguable if you want to call it a hybrid or not. You know, we say it's virtual delivery, but you know, we do that intake over the virtual platform as we described. We do all of the preliminary outcomes, etc. And we require the patient to come on site for 2 visits. So they come on site initially so that we can do their 6-minute walk test in a one-on-one format, and also so we can get some of those important signatures on the informed consent, maybe answer a few questions if they struggled with the outcomes. Also at that time, and why we bring them here, is we're giving them some home material. So we give them their education booklet, we give them a pedometer that's downloadable, we give them a TheraBand, and we're looking at expanding some of the things that we offer them for home, but it also lets us get some insight, you know, do they have home exercise equipment, etc., so we can write a good prescription. All of their recurring visits are done in virtual delivery. So I should say at that intake time also, you know, we teach them how to use Zoom and how to use the technology. We didn't do that initially, but we learned that that was a pretty important piece of that early orientation once we got the classes rolling. And so the recurring visits, you know, they're doing about 12 sessions, maybe up to 18, depending on their risk. We do 25 minutes of exercise and we do 10 minutes of education on that virtual delivery. We maintain the ITP. We do everything, you know, as we normally do in our traditional cardiac rehab program. I should say that the CMS side of service waiver is an important piece to the billing. With the CARES Act, we can deliver this virtually, but if we don't put in that side of service waiver, it's a 40% reduction in reimbursement. So that is an important caveat for your regulatory compliance. And so with that side of service waiver, it's a regular build session. Nothing's really different there. So they go through the program, they come back for their discharge. Again, we do those outcomes, 6-minute walk test, get the pedometer back, download it, do some wellness coaching in that final session, and they bring some of the materials back and on they go. So it does require them to be on site for a couple sessions, but mostly virtual. Interestingly enough, we had set this up to be a program for folks that were trying to avoid the hospital for COVID, but we have reached an entirely new demographic and we've expanded the use of this virtual program. And I'd say primarily it's being used by folks who had transportation challenges that maybe, you know, live a little further away. We here in Chattanooga, we're kind of in a valley where we're landlocked by a few mountains. And so as the bird flies, there are people that are rather close to us, but it's a difficult trek to get to our centers, and they're really capitalizing on this offering, and we're seeing an increase in those populations, which is, hey, that's the silver lining. We're reaching more people, so we'll take it.
Yes, absolutely. Yeah, anything we can do to increase the reach is very important. And so along the same lines, Sarah, I know your program covers several institutions, and so and I think that's the same for a lot of programs around the country. So what has been your experience there?
So we are offering virtual cardiac and pulmonary rehab, and one of the things that happened with us is that one of our sister hospitals that is about a half an hour away had to shut down their program due to staffing issues. So with the virtual, we were able to still offer cardiac rehab to those patients despite the geographical distance. We also have some rural areas around us where we are the closest hospital, and we're hoping to reach that demographic better, but there are still, I think, barriers to be addressed in terms of internet access and good connections. So we have had some experience with that with the patients that would like to do it, but that is, they don't always have the best connections. And so hopefully moving forward, this is something that we can look at and assure that, you know, we can deliver this virtual care moving forward. But it has worked well for those patients that don't want to come in person or who live too far away.
Very good. So, you know, this virtual cardiac rehab, I think it is important to keep in mind that this is one way of increasing the reach and delivery. A lot of patients, clinicians, and cardiac rehab professionals might think that, well, it is not cardiac rehab if you're not actually with the patient. Well, it might be the case because you're not in the same room. You may not be using the treadmill that you want them to use. They may not be using the bike that you want them to use, and so on. But it is still another way where you can deliver a monitored a program for exercise, for education, for counseling serially over time. And the data is out there that you do achieve at least some of the benefits of in-person cardiac rehab. So in the statements that recommended by AACBPR, by the AHA, and by ACC, this is an acceptable method of delivering cardiac rehab. And so kudos to you guys and to all the other programs around who are able to deliver this and adapting and learning how we do this. And this is certainly a very dynamic field where we will continue to learn as we go. And so Heidi, beyond the exercise portion of this, you have been quite forward-looking in delivering a slew of other angles and perspectives there to your patients.
Yeah, so prior to the pandemic, we used to have an on-site dietitian and on-site health psychologist that met with patients face-to-face. But when we shut down for COVID and we were just offering our services over the telephone, it allowed us to offer our dietitian and health psychologist over the phone to consult these patients, and they didn't have to be on site and face-to-face. So that opened up a door for us to continue these services once we started bringing patients back on campus. So what really worked out well is that our psychologist and dietitian, who were only for our main campus patients, since they got used to the virtual platform and using telephone and video, they're able now to reach out to our 6 other sites that are in the region who did not have a dietitian on staff or who did not have a health psychologist. So we've been able to expand our services significantly to the population that would have no connection with these 2 services. So it's worked out really well.
Good, excellent. So a couple of questions that came through the chat box about, for example, for Matt, what is the 1 or 2 things that allow you to say, well, this patient is definitely not virtual rehab material. We wouldn't offer them that.
Yeah, we do use risk stratification as a guide. So if we have high risk patients, I will say that's not an absolute contraindication, but it is something that we look at and we have an honest discussion with them on the safety and validity of a program at home. Patients who do not have a caregiver, and I probably should have mentioned that, one big piece of our liability statement that we explored early on is we decided that we would make it a program requirement for virtual delivery that the patient state, and we have the expectation that they have a caregiver on site. We are doing this virtually. We can see if they're having issues, but heaven forbid they have a true adverse event. We want someone to be there that can initiate emergency response, even though that's something that we can do. So we put that in the informed consent, and they comply with that. So if someone doesn't have those opportunities, or they're really just limited by the technology, we've had patients that have wanted to participate and said, hey, I'll do a phone call, I'll do speaker. We're not comfortable with that. We need the visual. We need to be able to hear them. They need to be able to hear us. I would say that's the biggest absolute contraindication to participating. So yeah, that is limiting to some people. And we've been looking and exploring some grant dollars to maybe open up access that's specific to our Chattanooga area, interestingly. So hopefully that comes through.
Excellent. And Sarah or Heidi, when you offer virtual rehab, do you leave that as an option to patients, or you make a determination this patient is going to be virtual and this person is going to be in person?
We usually leave it as an option for the patients, but then also do some of our own risk stratification if that's the route they want to go. But yeah, it's basically presented, would you rather come in person or do virtual rehab?
Excellent. Heidi, anything to add there?
Yeah, we let our patients choose if they want to come on site or do telephone or do video. What I often tell patients, or I tell my staff to tell patients, is this is a great opportunity to practice out or to trial our virtual capabilities throughout our hospital to make them more comfortable. So if they do need to meet with their other providers, that they could do those virtually if they choose. So I say our dietitian is really informal, very relaxed environment. And if it doesn't work out, she'll just give you a call. And so patients have been really receptive to that. And we've really helped them try to learn how to use their virtual capabilities.
Excellent. And before we move on to the next slide, question that came from Matt here, or for everyone or anyone who wants to complement that. What platform are you using for virtual CR? Are you using anything specific or just a Zoom or WebEx for your through your EHR?
Our parent organization, Common Spirit Health, has decided to use Zoom. So all of our colleagues have secured accounts through hospital credentials. So we early on, before we were set up with that, we had some people using their own Zoom accounts, and that worked okay so long as we were on the hospital secured network. But we use that now.
Okay, and a quick poll, Heidi, what are you using?
We are using Zoom through Epic.
Okay, and Sarah?
We use a platform called Amwell, which the hospital uses for its virtual visits.
Virtual, yeah. Okay, and Jesse?
We have ClickSoft.
Okay. So this tells you, to everyone in the audience, the 140 people or so we have, is that you can pretty much use whatever you have within your system, and most platforms will work. So this is very encouraging, and we heard a lot about things that worked and that you will hopefully continue. But how about things that didn't work? And we'll just go in my screen here. We'll start with Matt, then Sarah, then Heidi, then Jesse for in a minute or so.
Oh, only a minute to tell you the things that didn't work. I will just say absolutely. I will say kind of generically that, ultimately we've had to ask the question in our centers, what is best for our patients? And knowing how limited we have been, we found that being transparent with our patients, especially with the immense amount and the rapid amount of change that we've had, early on to now, we ask our patients what they think. We ask them, hey, we think we're going to do this. We want to try that. What's your input? It doesn't ultimately lead to our decisions, but it is a big part of it. We have rolled some initiatives out that I've seen great pushback from colleagues within our own program, virtual rehab being one of them. And now those folks are teaching the virtual rehab classes and they love it. So don't be turned off if you get some pushback, because that's innovation. But you got to try it. My big thing with the virtual delivery, and people have pushed a little bit and said, well, is this safe and is it best for the patient? We just keep asking, is it better to give them nothing or give them something?
Yep, absolutely. Sarah Schaub?
I would say for us, it was when we were doing the group orientations, I had it all mapped out, like how it was going to work and the time frame. And when we first started doing it, it did take longer, and it was it was more, we were kind of fumbling through the process. People were trying to do it the same way they had done it before in a shorter amount of time. And so it took a while, and feedback from the staff to kind of adapt the vision to the reality. And so it wasn't like it was perfect from the get-go, but we made it work for the different locations. And, so it was sort of one of those things where with most of the planning, we had to make adaptations once we had some feedback from the staff and from the patients on how well those ideas were working. So yes, tenacity in making changes and taking feedback to make things better.
Yep, absolutely. Heidi?
Yeah, so there's a couple things that we did that we're definitely not going to carry on into the future with us. And one of those things is we, in the beginning, wanted to limit the contact of patients on site. So we decided to split our intake sessions into two parts. We would do half the session over the phone, and then we would bring them on site and do the rest of the portion. So the physical assessment, the surveys, and the 6-minute walk and exercise. And what seemed to be good in the beginning made us realize that we were just doing extra work. It was double time for the staff. And then also you're doing all this work on the phone with the patient. And if they never show up on site, you never really have a billable session. So we decided to get rid of that, that portion of our orientation, and we just do everything on site. And then another thing that didn't work for us, and it kind of was out of our hands, but we've changed things going forward, is we were only allowed to see patients on site 1 time a week. And what I found with that is these patients, it was just taking us so long to get them through the program. And then their lack of participation was down, just coming once a week. So I'm really glad we're able to now see patients up to 3 times a week. It's helped us get them through the doors, but then help keep people more engaged.
Absolutely. Jesse?
I just want to reiterate what Sarah said about the group intake. You know, it's something new for everybody, and with that comes some bumps in the road. We had the same idea. This is the way it's going to work. This is the time frame. And the first couple weeks, it takes longer, or you have that patient that's just a train wreck. So, you know, the staff always come together. We look at how we can change it, and we developed the motto, "Kiss it" around here. Keep it simple, stupid. And it just helps. We use that with our intakes. We use it with our care plan documentation, because the simpler it is, the more time you have to spend with the patient.
Absolutely. Yeah, we're all doing this for the patients. We keep that in front of us. And so it requires some adaptation from us, but you guys have been troopers, and what you've been doing is really exemplary. And I'm sure a lot of programs out there in the country are doing a lot of things like this to keep this program doing, keep these cardiac rehab programs going. So thank you all. I'm gonna transition back to Steve. I thank our audience. And Steve, there you go for your polling question.
Yeah, thanks very much. If you could just take a second, we always are thinking ahead about what would benefit you. And so if you could just identify, we're thinking about some smaller groups where you might want to spend several sessions discussing a specific topic with each other. So and perhaps working to implement those changes. So if you could just check the options below that would be of interest to you, if any of them are, that would just help us in terms of future planning. And I know it's going to take a second, so we can leave the poll open a little bit longer. When we circulate the slides, one of the resources that was mentioned in the next event, you'll have that in the slide deck, and we can probably go ahead and close the poll now. But we do want to thank you for being here today. The next date and topic will be announced shortly. That's going to be informed by your input on the question that you've just been answering. We encourage you to use the website to continue discussing things with your peers. And after you close the slide, after you close the event, we would really appreciate it if you provide us feedback on a few very short questions. It just helps us to see what we're doing well and what we can continue to work on to do better, since that's our goal for these events, just as we've been talking about, that's your goal for your patients and your programs as well. So thank you very much. Thank our panelists for a great session. Lots of just street smart, intelligent, operational changes to make things better all around. And it's great to see. Thank you very much. We hope you have an excellent rest of your week, and we look forward to talking to you again on a future affinity group session. Have a good day.